ways to make sure that we have students joining. Which means that even if maybe some people want to stay, but at 3:15, don't be alarmed if you see, if for some reason we end up going a few minutes, don't be alarmed if you see people just leaving because they have classes after. So it's not an uncommon occurrence. So that's that's basically it. So I was telling Song John that in normal times we will have invited you to campus. Of course, I know that not having the travel also helps.
Yeah. I think that this is here to stay.
I think this part of the talks and just bringing. I was talking to a friend, and like academics, we do have a big carbon footprint with traveling.
Absolutely. Yeah.
We're having some students who are starting to join, but yeah. So I think in that regard, there is. I get very tired with the professional conferences though online. It's very it's too much.
So there are too many, right?
Too many. Just at the same time, we're doing it at the same time that we're still doing all the other things. So it's like,
and then you have to sit down, and then like staring at one place, which is very unnatural in real setting, right? You walk around, you make sure that you have eye contact with everyone, but I think I found it physically very demanding too.
It is physically demanding in a yes. Yeah, absolutely. No, that's for sure.
Quickly to use the restroom.
Absolutely. Just take your time that this is the moment to do it. Same thing for you, Song Young, if you want to. I'll probably do the same actually before we start, but I see.
Great, I will do that too.
So funny you say that, Angelica. In my old office at CJ, I used to have a standing desk. So when I got tired of sitting, I would just stand up.
Yeah. And do you know what? So the funny thing is that I've always worked in front of my computer all the time, right? But class was not that. So there was that break.
Mm-hmm.
And the teaching in Zoom is very demanding because there is, like, I think it's a different strain in your eyes than just reading the documents or like just typing or Googling. It's just different. Actually, I think my vision got worse this year. I need to go to the doctor to check. I'm not kidding. Gloria, hi, I see you connected.
Hello, how are you?
I'm good. Thank you for joining us. So, is Agnes joining us soon?
Yeah, she'll be joining shortly.
Okay, perfect. So, I'm gonna take a quick break, and then because as soon as she, I just wanted to. Oh, and you said that are you gonna handle her PowerPoint?
It's Kadest, my other colleague. Yeah.
Okay. Perfect. So as soon as she joins, we can check that it's working. The sharing is working well. It shouldn't not work, but so it's best to double check. So I'll be back in a minute.
Okay.
Yeah, she's just taking a break before it starts, so.
Good afternoon, Professor. How are you today? Unmute. I was on mute. Sorry. No worries. I'm Judith. I'm the administrative assistant of political science. Oh, there she is. And I just want to make sure to welcome you while she was away from her desk.
Sorry, thank you, Judith. Hi, Agnes. My name is Angelica. Thank you so much for accepting our invitation. It's really, truly wonderful to have you here today.
It's my pleasure to join you. Thank you, Judith. Thank you, Angelina, for welcoming me.
Oh, no, it is truly a pleasure. So we will be starting shortly. I was telling the other two speakers, Song Jong and Agustina, that I will start with you, if that's okay. You will be the first.
I have no problem. I'm ready.
Perfect. And I also wanted to make sure that I'm pronouncing your last name correctly. Isbinaguajo will be the right way to say.
Very good. You've got a diploma in my language. Right away. it's okay. Very good.
I was actually like your experience is quite amazing actually. So I'm really looking forward to hear your perspective on this as a physician too. Like we have two political scientists, but it's gonna be very interesting to hear your perspective.
Fantastic.
And you are currently in Rwanda?
I am in my home in Rwanda, yes.
Oh wow, that is fantastic. Well, thank you very much.
Since the beginning of the COVID, by the way.
Oh
I
wow,
was
so you've been
lucky
there.
to go back home just the time it was not yet a pandemic, but I can see around the world that things were wrong. So I decided to pack and go back home. I was supposed I was in Europe in transit to go to the US, and I said, no way, I cannot. I'm going home. We are going to crash. Everybody is doing insane thing, doing no protection, no information. I was in Belgium at that period, and Italy was totally upside down. And the Minister of Health in Belgium didn't advise parents not to send the children for school tour in Italy.
Wow.
It was a mess. I was so upside down, and I decided. I said, no, I'm back. I'm going home. And the day I arrive home, then the mess starts to be openly talked about.
Wow. So you just traveled right at the nick of time. That is.
Yeah, I was so happy because in airport there was in my country there was already contact tracing, etc. In case of, because we knew that one day it will pass by. In Europe, nothing. You pass through airport, thousand and thousand of people a minute, and no protection for anyone.
Wow. Wow. That's a completely different reality. So I think I wanted to ask the three of you, Song John, Agustina, and Agnes, if it is okay with you if we record the session. At this point, we don't have plans to post it, but if we do that, I'll let you know. But for now, we just want to make sure that we have the recording. Is that okay with you if we record the session?
No problem.
Okay. Agustina, is that okay with you? Okay, fantastic. We have one of our faculty members has just joined. Professor Vanessa Gray is there. We're good. So just make sure we give a few more minutes and then we'll get started.
Good. We hope to contribute to awake the world because it's not the last pandemic, and we need to take lessons.
Absolutely. Absolutely.
Angelica, are you going to record it?
Yeah.
Okay, thank you.
Or do you want to... Well,
No, go ahead. Go record it because I have a lot of stuff on my computer.
Okay, no, I have like that. Okay, let's do it. Okay. The worst part of the beginning of these events online is just this first few minutes when nobody knows what to do except waiting. Just wanna... Oh, we have another of our faculty members has just joined, Professor Miniju. And two more of we call her our fearless leader, the chair of the Department of Political Science, Arte Tongmong, and then Professor Joshua Dick has also joined. Thank you.
Hi everyone. So nice to see all of you. I'm really, really excited to listen to and learn from you guys. I'm really excited about that. Thanks so much for being with us.
Our pleasure.
We also have our Associate Dean, Sue Kim, has just joined. And we also have Imogen Stalken, who is, of course, and we have tons of students, so I'm very happy to see the...
Yes, I want to know if Kedes, my assistant, is there because she has my slides. Kedes,
Gloria, Kedes, I saw her, yes, I see her.
Perfect.
Okay. So, I think we can get started. So good afternoon, everyone. For those of you who don't know me, I'm Professor Angelica Duran Martinez. I'm an associate professor in the Department of Political Science and co-director of the Global Studies PhD program. And it is my pleasure today to welcome you all and to welcome our speakers to the second spring event of our Brad Morse Speaker Series. Brad Morse Speaker Series is a series that we started in 2006 in honor of Bradford Morse, who is a native of Lowell, and he was a late congressman who in 1972 was the Undersecretary General of the United Nations, and up to this day remains the highest ranking American in the United Nations. So this series is really aimed at promoting his own vision, which was one of global humanitarianism and an understanding of international ethics. So today, we're very happy to have an event to reflect on the implications of the COVID-19 pandemic in Asia, Africa, and Latin America. And we're very happy to have three wonderful speakers. And as we know, the pandemic has really affected the regions of the world differently. It has highlighted and worsened existing economic and social inequalities, not only across countries, but also within countries. And at the same time, the pandemic has challenged the and put to test welfare systems, technological access, health infrastructures, and has also created enormous dilemmas for the governments around the world in terms of the balancing needs like enforcing lockdowns and doing contact tracing, while at the same time respecting civil liberties and maintaining accountability of police forces and democratic checks and balances. We really have a wonderful balance of positions today, and I'm sure that our speakers will be illuminating us on some of these issues. So I'm going to introduce them briefly, and then each of them is going to present for about 15 minutes. We don't have a ton of time. I'm sure that we can do an entire day about this. But after they talk, we'll start having a Q&A in the same format that we have these Q&As now. You can just raise your hand with the hand raise function or write your questions in the chat, and I'll do my best to make sure that I tell somebody who wants to talk or read the questions from the chat. And Judith is going to be helping me so I don't miss anybody. So let me just introduce briefly our three speakers. Our first speaker is Professor Agnes Binagwaho. She's an MD, a pediatrician, and a PhD, and she's the Vice Chancellor and co-founder of the University of Global Health Equity. She's a Rwandan pediatrician who returned to Rwanda in July of 1996, 2 years after the 1994 genocide against the Tutsi. Since then, she has provided clinical care in the public sector and served as in the Rwandan health sector in high-level government positions, which include the Executive Secretary of Rwanda's National AIDS Control Commission. She's also was Permanent Secretary of the Ministry of Health, and lastly, Minister of Health for 5 years. She's a professor of pediatrics at the University of Global Health Equity, a senior advisor to the director of the World Health Organization, a senior lecturer in the Department of Global Health and Social Medicine at Harvard Medical School, and an adjunct clinical professor of pediatrics at Dartmouth Castle School of Medicine. She's also a member of the U.S. National Academy of Medicine and a fellow of the African Academy of Sciences. She has published over 200 peer-reviewed articles and was named among about the 100 most influential African women in 2020. Our next presenter is Professor Song-Jong Oh, who is an associate professor of political science at Bryn Mawr College. She specializes in international relations and comparative politics in East Asia. She serves as an affiliated faculty member at the Center for the Study of Contemporary China and a faculty director for the Global Immersion Program in China and Korea of the Wharton Business School at the University of Pennsylvania. Her broader research interests include China's economic statecraft, the nexus between economy and security, industrial upgrading, and she was also a postdoctoral fellow at the Center for the Study of Contemporary China at the University of Pennsylvania, and was a visiting scholar at the Chinese Academy of Social Science in Beijing. And recently, I will say she published several interesting articles and opinion pieces related precisely to the pandemic and the responses primarily in China and South Korea. And last but not least, we have Professor Agustina Giraudi, who is an associate professor at the School of International Service at American University. Her work addresses debates on subnational and national democratic and semi-authoritarian regimes. She also has research on subnational politics and unequal access to the provision of public goods. And she also has research on institutional integrity and accountability. Her book, Democrats and Autocrats, was published by Oxford University Press in 2015. And she's also a co-author of a co-edited volume called Inside Countries, Subnational Research in Comparative Politics, published by Cambridge University Press in 2019. Her work has appeared or is forthcoming in several important journals like the Journal of Politics or Perspectives on Politics, among many others. And before joining American University, Professor Giraldi held a postdoctoral position at the Harvard Academy for International and Area Studies. She taught at the Universities Torcuato Di Tella and San Andres in Argentina and worked as a consultant for the Ford Foundation, the Inter-American Development Bank, the World Bank, and the Anti-Corruption Office in Argentina. And recently, she's been working on collaborative work that is examining how political factors are affecting responses to the COVID pandemic in Latin America. So we truly have an amazing group of scholars, and thank you again for joining us today. So we're going to start with Professor Binagwaho. So the floor is yours. So thank you so much.
Thank you, Angelica, for having me and all your colleagues, and also for organizing a so important gathering and discussion. First of all, good morning, good afternoon, or good evening to all of you around the world, because I know that you are listening to us from around the world. And I'm going today to focus on the impact of the pandemic on health system and health outcome on African continent, but also on the US and Europe, comparing. Let's go to the next slide. In this graph, the green section on the top of each bar represents the relative numbers of cases in Africa. As you can see, current cases in Africa constitute a very small percentage of the total number of cases globally. On these slides, you can see the same situation applied to the number of deaths. And that was not expected, because despite this reality, the narrative about Africa preparedness and response has been aligned to everything except the truth. Prior to the pandemic, Africa was expected to have 10 million COVID-19 deaths. The Global Health Security Index predicted that the US was the most prepared country for any health threat, and that Africa will fail any public response to any pandemic. With many focusing on our limitation in Africa, such as the limited number of test capacity, the climate in Africa, instead of our rapid and strict implementation of science and of various public health measures, both nationally but continentally, such as what we did, led by Africa CDC. This contributes to the North-South paradigm of white supremacy, believing that solutions always are originated from the North and Africa have to fail. It is also the reason that many high-income countries fail to learn from low and middle-income countries when they were dealing with spikes of number of cases and deaths due to COVID, when the implementation of some strategies have shown solution in low and middle-income countries. This past year has been detrimental to health system across the globe. Sorry. not only there was a shortage of space and equipment, but healthcare workers who take care of patients suffering from COVID were overburdened. Initially, there was a significant shortage of PPE, exposing health workers across the world to COVID infection and death. This physical risk was also coupled with mental and emotional stress of dealing with unnecessary suffering and death of their patient due to lack of preparation. And also, when I say preparation, it's not of the health workers, it's in the side of health system builders and politicians. And across the world, they had to deal also with isolation from their families so as not to expose their beloved to the virus. See here, the next slide, the number of infected healthcare workers as of July 2020, 10,000 healthcare workers in Africa had been infected at that time, and 150,000 in Europe were affected. And only 9 European countries have those cumulative numbers. You will notice that these numbers are from last year because today, to have the exact number of COVID-19 cases among health workers, it's difficult because not tracked regularly, making even more difficult to understand the challenges they face and have also as we face a disruption of health services worldwide. For instance, between March 2020 and March 2021, 12 million women have experienced disruption in family planning service globally. This largely affects the vulnerable in each country, but also more the poor countries than the rich countries. And if you look at the impact of COVID-19 on health system in the US and Europe, you can see the same results. There was a significant shortage of PPE in the US and Europe, even though some of the equipment bought by vulnerable countries, when I talk vulnerable countries, it's countries that doesn't have the same power on the global stage. The disruption of goods and equipment like PPE and respirator have seen some very rich country like the US stealing what was bought by less powerful country. The disruption of healthcare system also apply to the rich country. For instance, the number of patients in England waiting today, they wait today more than 52 weeks for routine treatment. Those numbers exceed more than 300,000 in January 2021 that are waiting more than 52 weeks for routine treatment. We also see deepening inequities in the developed countries. For instance, in September 2020, the Black people made up to 30% of COVID-19 cases, but constitute only 13% of the US population. Those with less stable employment during the pandemic lost their job, and they are the majority among the people called as people of color, as well as the insurance, they lost it because it's linked to employment. And thus, COVID-19 did not create inequities, no, but has exacerbated the existing one. Now that we have compared the impact of COVID-19 on health system in Africa, US, and some part of Europe, and just a little comparison, I agree, but 15 minutes is little to do more. We can look at the contributors to the successful preparedness and response effort in some African countries. And not only African, can see also Singapore, you can also see Vietnam. And with a specific look at lesson learned from Rwanda, because it's the country I know the best, In Rwanda, we paid great attention to the emerging of local and global contextual factors in order to adapt what we knew and adapt the evidence-based intervention known. Nothing was new. What we do is not new. We knew to have a mask or social distancing since H1N1. And in a way that works best for the country, we can adapt the message we give to the communities and the explanation. If the evidence-based intervention are the same for all countries, their implementation are adapted and have to take in account the local context. We use various strategies to implement this EBI. We use data. We integrate the response into policies and guidelines that were already done. It's not the first outbreak we face, and a pandemic is an outbreak in country and in many countries around the world. But in your country, it's an outbreak. So we use the lesson learned from previous outbreaks, and we emphasize what was risky: border and traveler control, multi-sectoral collaboration, because it's not a health sector issue, it's an economic issue, it's a transport issue, it's a cross-border issue, it's a Minister of Transport issue. And we focus on primary care to prevent that people die from other causes than COVID, because the health sector has diverted all the resources, space, and personnel to respond to the pandemic. So, for the next slide, you can see that we also promote innovations, leverage the accountability of leaders at all levels, each head of village, and I'm living in a village, meaning the 200 houses surrounding me. We are a village and we have elected a head of village, and that person is responsible to make sure that the poor in our village have food on their table every day for the entire family. So also we ensure that everyone could follow the COVID-19 guidelines, because some people are too poor to respond to an instruction of lockdown if they don't have food. So we need to bring them food. And also we provide financial support to the many people who are living, not working in a formal sector, but in informal sector, because they don't have saving and cannot survive a lockdown. Now that we have also started the vaccination campaign in Rwanda, I also want to share with you the strategy. First and foremost, like always, we follow science, prioritizing, and the science told us that we need to prioritize health workers, community health workers, those who are in front line, but also those who have underlying risk condition, but also those who are living in very crowded situation. And many of them are not Rwandan. Many of them are living in our refugee camp, or are Rwandan living in a prison. And it's very important to understand that those two categories are important if you want to stop the spread of the pandemic. So we also brought the distribution to a decentralized level up to health centers for the vaccination, and a health center serves around 15,000 Rwanda. Rwanda also had a coordinating organization to respond to the pandemic, but also to organize the distribution of vaccine. So, and the two images on the left show you that from the moment of landing also the vaccine, everybody in concerned knew what to do. So the vaccine arrived the night of the 3rd. They were stored, and all the boxes were put in an electronic file, and in the morning distribute to all districts, and from the district all sector came and take the quotation, the number of vaccine for their health centers. For the districts that were very far, we used helicopter from the army so that at before 4 that day, all the country was served. And the day after, the vaccination start the same at the same hour across the country according to the plan I talked to you. Health professional, community health workers, people at risk due to clinical condition, and people living in crowded situation. So in less than 10 days, we managed to vaccinate all those people with the vaccine we have, and we hope to have more vaccine because it's not enough. So, amid this crisis, Rwanda has shown promising trend in health service coverage. We didn't lose the capacity to provide primary care. And you can see that in this graph, where you can see that delivery in health facilities, family planning tools, vaccination of kids didn't decrease at all. So this since more than a year now, because the first case in Rwanda was the 15th of March 2020. So despite this relatively successful response, like many African countries, we face various challenges. Economic crisis caused by the pandemic threatened to increase unemployment, especially given our large informal sector. We also face significant challenge with regard to COVID-19 vaccination rollout. We don't have enough vaccine. We are now mobilizing all the world to create the capacity of Africa to produce vaccine. But we face legal problem, and we face the fact that there is a huge opposition, even if was it Pfizer or other vaccine, they developed the vaccine with public money, not with money, private money only. And they are the only one to benefit of that. When we say share so that other place in the world can build or can do vaccines so that they can save more people, they refuse. But they never refuse public money to develop their own vaccine. So this is a limitation of life-saving medical intervention that could save life. The continent, through our leaders today, head of state, international organization, university like my university, all over Africa, we are advocating for that. Before I finish, I want to say a few words about what needs to be done moving forward. While we have to keep advocating to access to vaccine, we also need to continue implementing the non-public health measure adapted to the local context.